Now we delve into our conversation tonight, and we start off with some quick statistics. 756 drug-resistant TB cases were recorded in the year 2022, highlighting the need to have this issue addressed even as the world is preparing to mark the World Tuberculosis Day tomorrow. And as such, tonight, my guest is none other than Caren Mburu, who is a senior technical advisor, pediatric and adolescent at Elizabeth Glaser Pediatric AIDS Foundation. Thank you very much for making time, ma'am. Now, we've already seen the statistics. Several years down the line, we're still tackling tuberculosis. But now in the recent days, we've seen Kenya adopt a guideline by WHO that recommends short-term treatment of tuberculosis 1, I think type 1 in children with non-severe disease. Unpack this for us.
Yeah, thanks for bringing that up. TB is still here with us. We are still not where we should be with regard to case detection and coverage with treatment. Yes, WHO provided new guidance around shorter courses for treatment and even shorter courses for prevention. And as a country, this guidance was adopted quickly and incorporated certain aspects for treatment decision making, especially for children. Because for children, you have to rely heavily on clinical decision making, not so much some of the lab work that is required to be done for TB. And through various processes and stakeholder engagements and development of standard operating guidelines and, adaptation of the algorithm for diagnosis, all the way to piloting some of these tools, and now the rollout of shorter course treatments for children since January 2024. So what does short course treatment look like? Typically for pulmonary or some other non-severe forms of TB, for example, those affecting the lymph nodes, we treat for 6 months. So we give an intensified course for 2 months with 4 drugs, and then we continue for another 4 months with 2 drugs. So this has come down to 4 months in total, where we have an intensified course for 2 months and then the continuation course for another 2 months. And we are really excited that this also is for our children. TB treatment presents a pill burden across populations, and how much more for children. So what we anticipate to see, and what has been proven what has been proven really, is that shorter courses improve compliance. I think if you are given 6 months and 4 months, you choose the 4 months. Actually,
when you say that, you picked it from my mind, because growing up, when we were attending sensitization campaigns on tuberculosis, where you should cover your mouth when you're sneezing and such, it's because this is how it was said, and it was said in Swahili. Ukikosa kumeza tembe moja, unarudia. So that, I mean, it's a shorter term would mean more compliance.
Absolutely.
But then there's also another issue that we also need to look at, and this is the cost of treatment when it comes to tuberculosis is still considered very costly to a majority of Kenyans, not even looking at the globe itself. So as government is working towards universal health coverage, as a doctor, what do you think needs to be done to actually lower the cost of this kind of treatment?
I think our government has been really instrumental, together with very key partners, in increasing the access to TB therapy. In the public setup, you do not pay for TB therapy. In the private setup, you may pay for some of the services, but largely the costs are not there. But then that means, even with shorter courses, that generally that means that the cost comes down for a country to really roll out the shorter course treatments. And remember, these don't just affect the pediatric population, it will also roll into the adult population. So I think that in a sense may reduce the costs. But when you talk about universal health coverage, you have to think about it beyond just the facility setup. You're thinking, okay, we have to increase access to services, but we've got to start in the community. And within the community, in terms of case detection, and link it to the lower tier facilities, which to some extent have a way of screening and diagnosing TB and upward referral if really needed. This is still, TB treatment and TB strategy is really within the core of universal health coverage.
Now, you've mentioned something about early detection. Now, we have adapted these guidelines from WHO, and it somewhat presents a simplified diagnostic algorithm. How will this now help us early detection, especially where kids are concerned?
Yeah, that's a very important question. Children are not small adults. The way they present is different from adults in that one, TB progresses much faster, and it can present like any other respiratory illness. You know, under 5s commonly have respiratory illnesses. Yes. Can even present as a pneumonia. So you don't expect to wait, oh, I've been coughing blood, or what have you. No, for children, we look at very subtle symptoms, like just a low-grade fever, just feels a bit warm for over 2 weeks. Or the baby is not playing as much as they usually do, you know. The weight is faltering. It's not going up as it should, and in the extreme, it's even going down. So very subtle signs. Now, what the new case detection, or let me simply put it like treatment algorithms have done, is that one, they simplify treatment decision making for the healthcare worker, and they empower the healthcare worker. It is usually daunting to manage a child. You're like, oh, maybe it's not, let me first treat with antibiotics, let's wait it out. But then time is going and the disease is progressing in the child. So it makes clinical decision making simpler and empowers the healthcare worker to be confident to make the decision. It does still incorporate some aspects, for example, chest x-ray, but provides provision for settings where there is no chest x-ray access. So in a sense, that definitely, and we're already seeing increased case notification since January this year when the new treatment algorithm was rolled out in the country. So we trust that this will really ramp up identification of children with TB. Yeah.
As we're looking at report and statistics when it comes to the TB burden in the country, for this category, children, would you say that we are having more cases of TB recorded in children than adults? And what might be fueling this?
I won't say so. Children typically in Kenya are estimated to have a prevalence of TB of 10 to 15%. We've never reached the 15%. Actually, one of the goals of our new TB national strategy is to achieve 15% detection by 2028. So we've come a long way. I think at the end of 2021, we're at 11.4, and 2023 at 13.3, which is significant. Children as a population do not have higher prevalence compared to adults. But we are excited about identifying more children because we know, at least from 2020, 55% of children with TB were not identified. So we feel we are heading somewhere, even as we see the prevalence going up, because it means we are detecting them more. We are detecting them more, and therefore it means we can treat them early. And I must mention, Regina, that we can't forget some of the long-term consequences of TB. Even after treatment, we are now having evidence of chronic lung disease, even in the pediatric population, which generally increases the morbidity of an individual as you know, throughout their lifetime. So it is exciting to see increased cases being identified, and we really hope to reach that target of 15%. Yeah.
Indeed. Now, other than, as you said, lung complications, we're looking at the country and the globe at large. We moved away from the issues of COVID-19. What role did COVID-19 as a pandemic itself play in exacerbating the TB burden in the country?
Yeah, that's a good question. So both diseases are transmitted airborne.
Yes. Both
diseases manifest largely within the lung, although they can affect other organs. Both diseases share the risk factors. So someone with diabetes, someone who's malnourished, people who are of lower socioeconomic status and have less access to health, all those shared things really were shared between COVID and TB. But specifically around the impact COVID had on TB was we noticed a downward trend in case notification. That's not a good thing, because it is from identifying a case that you're able to link for diagnosis and treatment. So if you have less identified, it means they're still there in the community, they're not being diagnosed, and they're not being linked to treatment. Such that after the COVID period, then once the health systems were more open and cases, people could now come by demand. You see an uptick in the cases notified. But I must say also COVID, we had like a redirection of our resources towards COVID. We also had curfews, we had lockdowns and the like. So you'll sit at home with your symptoms. It's likely no one will come to you to screen and the like. So all these disruptions within COVID have impacted TB. And so we are seeing a rise right now. Initially, we also had a lot of people coming with, more disease that has progressed. So yes, it did have an impact. TB and COVID dance around each other. Each either can make the other progress faster. So there's always this dance between the two diseases.
So now we're recording an increased data. You're receiving a lot of data in terms of TB infections that maybe are a ripple effect of the COVID-19 disruptions there, but not necessarily that they were non-existent.
No.
Okay. Yeah. We'll take our first breather, but when we come back, we're going to be looking at stigma that is associated with TB and how it is affecting delivery of treatment and healthcare services for those who need it. Do not go away.
Friend huyu hapa na anakugoja *570# chagua option namba 4 na uchingize katika draw ya kuvuka namba 3. Mshindi tunamtangaza 5th of May. Kumbuka ni *570#.
Cheza Lucky Game na tunakuhakikishia ushindi na bahati yako itakufikia mahali popote ulipo. Kumbuka kucheza ni *570#.
Itakuaje? Oya.
Auntie akona ka forehead. Akona the mark of quality.
Ameke ramdene la mshetani over.
Nataka kumaliza mambo hiyo wedding.
Kwanza kiongea kitu cha Paediatrics. Rosipol.
Umenimaliza kama chai kwa kikombe.
September, October. Wanaona,
ni kama tu nikuje nikwambie uko na kichwa kubwa. Sasa makosa
au sio? Ndio manake. Okay.
Every Monday from 8 p.m. to 9 p.m. on KBC Channel 1.
We're marking the World Tuberculosis Day tomorrow, but where are we in as far as the disease burden is concerned here in the country, and what is being done to ensure that you get medical support and services if you are diagnosed with tuberculosis? We're joined by none other than Dr. Caren Mburu, who is taking us through this conversation. So before we took a break, we were just looking at the systems and what is working and what is not. Then there's the issue of stigma that is related to tuberculosis, emanating from previous campaigns, especially run in the early 90s and 80s, where tuberculosis diagnosis was linked to HIV and AIDS, and that whenever you hear tuberculosis, you think HIV and AIDS. From a doctor's point of view, how has this impacted on the treatment of tuberculosis?
TB, as a disease on its own, any person who has had TB, and if you hear stories from community advocates, there's always that aspect of stigma, because people think TB, first I will get, infected if I'm close to you.
Yes.
Yes, there were a bit of negative messaging earlier in the HIV pandemic around HIV that created a lot of stigma.
Yes.
Back then, and even today, we still have to test for HIV if you have TB, just because HIV increases your risk remarkably to acquire TB. But yes, stigma within TB itself is there, maybe exacerbated also by HIV, but it's important to know, both can be treated. TB can actually be treated and cured. And the community and people who live with people who have TB should be supportive and should be proactive also to have themselves screened and linked to treatment if necessary. So yes, stigma can make an individual be afraid to go into the health system for a proper diagnosis. You know, it may make a person be afraid to disclose that they do have TB, especially to those close contacts around them. And we do have to have a lot of advocacy within the community. We are happy about the community health promoters whose mandate is really promotive and preventive. Just to go in there and just let people know, just have an education about TB, because there are still a lot of misconceptions in the community. Yeah.
Now, we've been talking about, TB in children, pediatric tuberculosis, and you've mentioned the negative messaging that is also not correct information. And there's a parent there who is treating, or rather has a child who is suffering from tuberculosis. From a doctor's point of view who is dealing with children, how then do we offer support to families that have children who are undergoing treatment for tuberculosis? I'm sure it's not easy.
It's not easy, and we are so grateful that even for some of the therapies for children are child-friendly therapies. You can take a tub and dissolve it in water and give it to the child rather than have to break and do other things. So we do still sense a lot of parental, conflict in a sense, or denial of diagnosis of TB in a child. And Regina, TB happens in all populations, however rich or poor you are. Of course, there are certain risk groups, but there's always that thing of probably no, it's not TB.
Yeah, my son cannot be suffering,
but it can and possibly is TB.
Yes.
And therefore, parents just need education about what TB is, just to understand it and to understand it's treatable. And the more we delay in accepting the diagnosis, the more it impacts the person affected, who is the child, who cannot speak for themselves. So parents just have to be careful to ask the questions and to seek as much information about TB, but mostly to understand that it's a treatable condition. We have regimens for children that are easier to administer. We now have shorter course regimens for those with non-severe TB. I think it's more of a community perception and education that is really required.
Now, about perceptions as we come to a close, is that we grew up hearing that if I contracted TB, and you were standing or seated next to me, let's demystify that you're likely to get TB. Let's demystify that tonight.
Yeah. TB manifests in various forms, the most common being pulmonary TB. Amongst adults, they are more likely to be the ones who, if they cough, if it has advanced to that extent that they'll cough up the TB, we call them bacilli. And therefore, if you have an active case of TB that's pulmonary in the home, there's a risk for acquisition of TB for the household contacts, and especially the vulnerable household contacts. The grandma, the person who has comorbidities like diabetes, but then let's not forget that little child there. Those ones are at very high risk of acquisition. But the risk is even higher when the person is tested and found to have what we call bacteriological confirmed TB, that through molecular diagnostics or through a microscope, we're able to detect the TB. Then those chances become higher. But then there are other forms of TB that are not necessarily in the lung, could be around the covering that covers the brain, what we call TB meningitis, or in the gut and what have you, which may not directly transmit in that way. Regardless, I think, Regina, for households who have a contact of a person who has pulmonary TB, it is imperative that the contacts are just screened. And those who are symptomatic are tested. And those who are not are given preventative treatment.
I like that symptomatic. We had that a lot quite when we were treating COVID-19. We have been speaking to none other than Dr. Caren Mburu on, why we need to get tested, why we need to move away from stigma when it comes to treatment of tuberculosis, well ahead of the World TB Day that we're going to be joining ranks with other countries to mark it tomorrow. Thank you, ma'am, for your time.
Thank you.
Now we hand you over to the sporting arena with my colleague, Karen Kibet, who's going to bring us up to speed with what we should expect, especially towards the end of this week as WRC comes alive. Still keep tuned.